Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Before I introduce today's guest, I just want to take a moment to thank you for your support of the show. As I'm now just over a year into this podcast journey, the popularity of the show has grown so much, and I love hearing from listeners about how the show has helped you, whether it be personally, professionally, or financially. I promise to keep bringing you amazing guests who will not only inspire and educate you, but expand your reality regarding what is possible. And that actually brings me to today's amazing guest, Dr. Kristen Knecht. Kristen is a fellow UConn Ortho alum who is originally from Baton Rouge, Louisiana. She obtained her DDS from LSU in 2013 and her ortho certificate and Master of Dental Science from UConn in 2016. After completing her residency, she moved to Houston, Texas, and began working for a DSO, where she practiced for 3 years before taking the leap and opening her own practice, Knecht Orthodontics, in 2020. I'm really excited to talk with Kristen about her journey, including her transition from residency to DSO to owning a practice, and how her treatment approach has evolved during that time, especially as it pertains to early treatment and airway. So with that, I would like to extend a sincere welcome to Dr. Kristen Knecht to the Doc Podcast. Welcome to the show, Kristen.
Thank you. Thanks for having me.
You're welcome. Thank you so much for coming on. You're the second UConn Ortho alum that I've had on the show. First was actually my first ever guest a little over a year ago, Dr. Jeff Rothenberg. He graduated a year ahead of me. You were a few years behind me. But he and I talked a lot about kind of some similar stuff. And when I was going through in practice and doing a lot of my phase 1 arch wire expansion and early treatment, that stuff that we weren't necessarily taught in residency, which we'll talk a little bit more about, I was telling him what I was doing. And so he started incorporating some of that into his practice going back about a decade ago, or maybe even a little more. And so he came on and talked about how it changed his practice and changed the way he approaches treatment. So kind of similar in a lot of ways. But I think one of the main reasons I want to have you on is your story. I have a lot of different guests on. I try to give a broad perspective of guests from different arenas. Some of the people who are lecturing at the highest levels and are kind of names that people have seen and heavily published and get into the science and data. That's great. And those guests are awesome to have on. I love picking their brains and kind of nerding out on the science of it. That being said, that doesn't always translate to the way the average wet-fingered doc is doing it every day in their practice. And I get a lot of feedback from people, and I always try to listen to that and take it to heart. And a lot of people just don't know how to bridge the gap from going from kind of hearing about this stuff to implementing it in their practice. And I find that I had a guest on a few weeks back, Dr. Scott Province, who was a general dentist in Manhattan, and he talked about his journey in this arena and what got him thinking about things differently clinically. And I'm always so fascinated by that because that's where I was. I went on this journey and I've talked about that. And I find that if I bring people in who can share their stories, it really does resonate with the audience. So I really appreciate you coming on and being willing to talk about your story, because that's not always easy to do.
Yeah, of course. No, I'm excited to be here.
So the path you took, it's interesting. And I'd love to spend a little bit of time going into it, because while it might seem kind of unique, and if someone did kind of the straightforward go out, or maybe they had a family member in practice, they went and joined, hearing that you went from UConn to Houston, Texas, with a DSO, and then went, and 3 years in, and just went and started a practice. It may seem like a lot of big jumps, but interestingly, in talking to and teaching residents for many, many years, this is a similar trajectory to a lot of what our colleagues encounter. And if I have a lot of lay people who listen to the show as well, parents and patients. And if you're not aware, we don't get educated on this side of things in our residencies. We really might have a guest lecture here or there, and might have a part-time faculty member who gives us a little feedback, but ultimately there's no real course in what to do once you graduate, once you finish.
Yeah.
You kind of got to go figure it out and ask others that came before you and talk to friends and family and colleagues. So talk to me a little bit about that journey. How did you decide, after finishing up at UConn in 2016. Number one, that you were going to move to Houston, an area you didn't have anybody that I'm aware of that you had connections to. And then also as part of that, work for a DSO. Let's kind of just start that part of it.
Yeah, of course. So when I was in residency, I was married, and my father-in-law, who was kind of a mentor to me, was an orthodontist and pediatric dentist. He was dual trained.
Okay.
And my ex-husband and I got a divorce when I was in residency. And so I kind of was like, I don't want to go back home to Baton Rouge. I want to just start over and kind of create my own journey, my own path, have a fresh start. Mm-hmm. And I wanted to still be like close to home, but not too close. Mm-hmm. And Houston was 4 hours away. So I was like, okay, this is perfect. I can drive to go see my family. And given that I didn't know anyone, I wasn't really trying to get involved in a private practice because I kind of know how disruptive it is if an associate leaves. I wasn't sure, like, what if I hate it, after 6 months and I want to move somewhere else. And I didn't want to do that to another colleague. Versus I kind of knew at DSOs that there is a little bit of a revolving door.
Interesting. Okay, right.
Providers. And they also had great pay structure. Honestly, it's gotten harder and harder, I feel like, for private practices, like to find the right associate because they can make a lot more working for a DSO. And so it was just kind of a great starting point for me. And I thought, like, this will be great. I can kind of get my feet wet, figure out if I even like Houston and if I want to stay. And it was a great experience initially. Like when I first started, I had a lot of autonomy. I got to kind of get my feet wet, figure out the way that I wanted to do things, the way I wanted to practice. There's also, I worked for Pacific Dental. So there's other orthodontists for that same company.
Okay.
So you kind of had some resources too. Like you could talk, we had group chats with the other docs that were in the area.
Okay.
And so I started, kind of feeling like this was great for now, but not what I wanted to do long term. There just wasn't enough ability to like make your own decisions on certain appliances or how you want to manage staff, how you want to run things with the front desk, with the treatment coordinator. And then there's also no emphasis on patient experience. They're all like these very cookie cutter offices. You're working out of operatories that are meant for GP or oral surgery when you're not there. And so I knew that was, not my long-term goal. And so kind of around the time that I was thinking this was something that I wanted to branch out from, I ran into a UConn grad at a study club, and he approached me. His wife was also an orthodontist and UConn grad, and she was pregnant. And so they were looking for someone to come in as an associate and maybe help cover her maternity leave. Okay. And then with an opportunity to, stay on as an associate if needed. And so I started this associateship position, and I was splitting my time between my DSO and the associateship. And I still just started feeling like it wasn't going to fill that like itch to have all of the autonomy.
Yep.
And you're still coming into someone else's practice where like, it's not that that he wasn't open to suggestions, but it's like, okay, well, I've grown this practice to this level.
Yep.
And it's working just fine.
Right.
So why do I want to take your opinions on it?
Yep.
Using a certain bracket system or the way that they were doing things. And I just wanted like full autonomy. And I realized that I was way more particular than I ever imagined. And you're sharing cases, at least that's how we were. And I just wanted to be able to start my treatment plan, start to finish, complete it, and learn and review my own cases. And even in a DSO, I started kind of becoming like the fixer of the practice.
Sure. Yep.
So they would move me into offices that were struggling, and I'm like cleaning up other doctors' work. And it's not my treatment plan. I didn't start it. And then I might not finish the case before it's like, oh, we're going to move you to this office because you can't give us enough days. Like it was so many moving parts. And I wouldn't
like a transfer case in residency, right?
Yes. Except I was dealing with those like problem cases on a daily basis.
That's tough. That's a lot.
It was, I learned a ton, but it was not what I wanted long-term.
Yep.
So I decided, I was like, okay, the only way I'm ever going to be happy is if I take the leap and I start my own practice. And one of the
Now,
benefits
was this like, sorry to interrupt, was this,
yeah.
were you realizing this like a year? I mean, it was about 3 years you were there. Was it like a year or two when you realized this? When were you starting to realize it? And then how long from the time you were thinking this until the time you actually made that leap?
So I was starting to think maybe like 2 years in that I needed something else.
Okay.
And so that's where, when I was approached about this associateship, it was kind of perfect. I was like, okay, this is great. I'm wanting out of this model of practice anyways.
Yep.
And then it was maybe within like a month or two of being at an associateship. And I was like, why am I doubting myself? Like if they built this practice from the ground up, like I know I can do it. Like I have assistants that will drive an hour and a half with me to different practice locations because they want to work with me. Like I know that I can get a team behind me, be a good leader, and build something and do it my own way.
Yep.
So I decided that pretty quick. Like once I literally gave my resignation at my associateship after 6 months, and I put a letter of intent in on a space the same week.
Wow.
So the nice thing, and I'll say about the DSO, is I had built up a really good rapport. I was a high producer for them. I fixed a lot of their like messes. So they just let me come back whenever. They never wanted me to leave to begin with. So I was pretty transparent about like, hey, this is what I'm doing. So when I gave up the associateship, they just gave me some offices back.
Oh, okay.
So it was actually a very easy transition until I opened my office. And that's where I think that, sometimes people are so quick to say like, oh, DSOs are terrible, or it's not great to work for them. But it really was like this amazing stepping stone for me. And it gave me a lot of freedom to build a practice the way that I wanted to do it. And then even I told them, I was like, look, I'm going to build my own practice. They're like, we always kind of knew that you would do that. We'll take you as long as we can get you, but we knew that that was probably always going to happen. And so they let me work part-time when I was opening my office.
I was going to ask about that. If you did anything at all while you were building it. Okay. So really interesting. That's cool. So how long did that last? Would you say, how long did you have to work with them?
Well, I did it into a year of opening. So I guess I shouldn't even say I was doing it part-time when I was building it. When I was building it, I was working 5 or 6 days a week and living in like a studio apartment and saving up all of my money because I knew that I wanted to build like this really nice boutique style office. And when I started looking at the numbers and like what I was going to get from a loan, it was just not going to cover the way that I wanted to build it.
How did you know how to do that? Looking at the numbers, how did you know how to be that disciplined financially?
My dad is a business owner.
Okay. Got it. Yeah. Cause it's rare to have somebody who has that financial acumen and discipline to be able to make those decisions. So you kind of had dad as a mentor just to learn from
a mentor, a role model. He owned an industrial construction company when I was in college. I used to have to go and work for him. I knew very quickly that I wanted nothing to do with this business, that I needed to be,
tough business.
Dealing with people. But he taught me a lot about, how to run a business. I learned so much about employees from him. He had lifelong employees, and he used to always tell me like, Kristen, people don't work for a company. They work for people. The sooner that you can figure that out, the more successful you'll become.
Interesting. Yeah.
And it was true. I mean, it's been extremely true in my practice now. Like I have staff that have been with me almost 8 years.
Wow.
They came with me from
they followed me. That's amazing. That's amazing. Because that's one of the biggest challenges and things I hear from young docs is how to even start staffing places. And that's great. And it's great advice that people are working for people, not the company or the name on the door. And you have to treat them as people and as people that aren't just disposable entities. So that's really interesting that I guess let me back up a second. Did you have a vision? Because one of the things I do, I talk about on the show and I teach residents. One of the first lectures I give them when they're new residents and when I started at Nova is the vision planning, goal setting, and starting to think about what you want your life to look like in 20 years and then working backward. I do this with my own kids. I do it personally. So at what point did you know, I mean, when you were in UConn, when you were a resident, how much did you know about your bigger picture vision of what you ultimately wanted your professional career to look like, say, 5, 10, 20 years down the road? Or was this something that you didn't really know and you just kind of you were out there trying to figure it out? Would you say it's one of those extremes or kind of somewhere in the middle?
I mean, I would say it was probably in the middle. I kind of always thought that I would end up in private practice, but I just didn't know maybe in what way. Mm-hmm. And when I was in Connecticut, I really didn't, I felt like I was a little bit lost there for a while and like what my personal life and direction was going to look like.
Sure.
But once I started working, and I mean, I was working when I was working for this DSO, I was doing like 5 to 6 days a week. I was very hungry, trying to, save up money, get my feet on the ground.
Yep.
And it definitely, like, I feel like my vision became very clear through that process.
Okay.
Because I saw the way that I didn't want to practice pretty much.
Yeah, sure.
And that I wanted this like very welcoming environment where I could follow patients throughout their lives or treat their kids, treat all of their siblings. I didn't want to be this like revolving door, provider.
Yep.
And so that became apparent to me pretty quickly. But I feel like when you're starting out, you're just focusing on like doing the ortho because it's such a stark jump from, if you think about dental school, you can't move on to the next step until someone's checked it. And then like you can't fill your cavity prep until they've checked the prep.
Yep.
And then you go to residency and they start like slowly giving you more autonomy. But then all of a sudden you go to work on day one and it's like, wait, there's nobody there to
yes
for me to ask what I'm supposed to be doing.
We both know Johnny well, Johnny Feldman, who's just amazing. And I try to emulate him with a lot of what I do teaching the residents at NSU. And Johnny, for those who don't know, was a part-time orthodontist in Connecticut who was just amazing and comes in and he would teach us. At that time, it was Thursdays. He would come in and
still Thursday.
He'd come in and just was just a wealth of knowledge and really gave us that connection to private practice and kind of quote unquote real world that you really don't get a lot of times when you're just in academia. And there were times I literally, because I went out day one and started my own practice literally and we finished up UConn end of June, July 5th, I opened my practice. I did have the advantage that I was doing some moonlighting, and I've said it before, Dr. Nanda now knows because I've said it on the show. It was discouraged, but it's too bad it was discouraged because my family had a dental practice and I would drive back a couple hours to where we lived on some weekends. And it started just basically just to cover hygiene, because in New York State, you have to have a licensed dentist on site. And this was before New York State. Now, unfortunately, you have to complete a residency to get license. This was when it was still, you had to take at that point, the NERB, the licensing exam. So I had my license, my dental license, even when I was in my residency. So I'd go back and just cover hygiene initially. And then it started doing some hygiene checks. And then it was covering some emergencies. And then some of those emergency patients, because the docs in that practice were very busy, couldn't get them in for some simple restorative that was elective procedures. So they would ask me, hey, you want to do this? And next thing I know, I'm doing some crown preps and some endo I realized a few things. One, every time I took that drive back to UConn, I was so thankful that I was in ortho because I love general dentistry and I did feel I was good at it. It is a shout out to all the general practitioners out there. It is hard work day in and day out doing good quality general dentistry. So it is a lot of strain to do that. So I learned that I was I made the right choice for me as far as a profession, but I also learned a little bit of what it was like to not have someone right over my shoulder. I mean, if I needed my father or uncles, I could always reach out to somebody or call them, but it wasn't like, you're treating a real life patient. You're not going to be like, oh, hey, you come over and check what I'm doing here. So it did kind of give me, took the training wheels off a little bit and got me to be able to feel a little of that autonomy. So your point is so good because a lot of that's just a mental confidence to be able to make decisions without having someone right there to turn to and not doubt and question yourself. And as I started saying with Johnny, there were a couple times, even with that experience, when I would be in private practice, I can picture it. And I would literally be with a patient and I'd go to the back room and call Johnny. I'd like, hey, I'm like, I don't know, like, what do I charge for like this? Or just all those little things that we don't know and don't learn about. So that's interesting that you found that and I get that question a lot from residents is, that's kind of where that big gap exists, where they just feel that it's so hard to take that leap and jump over that gap. And I get it because for people who don't know, I mean, we become a little bit institutionalized. We're always having every chart signed, every x-ray signed off on, every, like you said, down to the crown preps or restorative preps in dental school. And then on into ortho, we have to have our treatment plan signed off on, and we have to have at the end of each day, faculty initial charts. And so and I'm not saying that's wrong. I mean, you've got to obviously have some guardrails up on people in their training. The tough part is once that's not there anymore, you kind of feel like, wait a minute, what do I even do now? It really is a bit of institutionalization. So so I really wanted to just kind of call some attention to that point. So you felt like that those fears in the DSO got you to take the training wheels off, where you realized what you could do on your own and gave you the confidence to know that you could do it without someone there?
Yeah, for sure. I mean, I was still doing the same, like phone a friend. One of my best friends that's also a UConn grad that was a few years ahead of me. Like, I'll never forget one day I hadn't texted him, 10 times. And he was like, "Oh my gosh, I think you're so grown up." And I was like, "No, I'm off today. I'm not working."
Oh, that's so awesome. That's such a great
story. He helped me tremendously throughout that process. But I mean, that's what we should be doing, is relying on our colleagues, helping each other out. But I think, the flip side is, even sometimes people think like as an associate, you're going to have all this mentorship. And I really didn't have that as an associate either. So the nice thing about the DSO is it just gave me the autonomy to, like, if in a year I really decided I wanted to leave, I didn't feel like it was as disruptive, because most providers were there a year each time. Like, do I think that that's the best for patients? Absolutely not. And that's why, I opened a practice on my own. But the reality is, like, they change providers all the time. Like, there's a DSO in the same parking lot as me, and they're on their 4th orthodontist since I've opened.
Right. So one a year. There you go. Right. Yeah.
Yeah. It's, pretty typical. So I didn't feel, bad about it. I felt like it gave me a lot of flexibility. And so there's also confidence in that. Like, I didn't feel like I would be stuck or, screwing over an old doctor that was like trying to like sell the practice. Like, I didn't feel like I'd be putting someone in a bad spot the same way I would if I joined someone's practice and then left. And that was honestly, like, my contract was for a year when I was an associate, but once I kind of started feeling like I was leaving, the wife was coming back from maternity leave. So I was like, it's honestly better if I leave now, because then you just tell all your patients that I was just covering her maternity leave. And it looks better to everyone, like, because I genuinely care about their practice as well. And I would think that any other associate would too. So you want to make sure that you're not doing anything that's damaging to their office.
It's awesome. You have that sensitivity to that. And it's really interesting. I never thought about it in that way, that because so many people, as I said, are afraid to take that leap to private practice. They feel like they need something in between, but much like yourself, are sensitive to the fact that if you go into a single provider office where this doc is looking for their replacement to phase down and ramp the other person up, and you stay with them for a couple years and leave them, that is really not the nicest thing to do to a C. Now, again, there's all sorts of situations, and it could be a bad work. And I mean, I get it. You might be forced to make a decision. I'm not talking about that. I'm talking about going in with the intention that this may not be a long-term thing, but telling them it might be. And I know why a lot of people are conflicted in doing that. And, as someone who interviewed prospective associates, that was always one big concern I had was, are you going to come in here and then in a year or two decide you're looking to move on or start your own? And because it's such a difference, whereas the corporate model, and for those who may not know DSO, if you're not in the field, it's dental support organization, and it's run by a corporate. So they're a big entity, a high corporate infrastructure, lots of offices, deal in volume. And that's different from obviously just a Dr. Smith or Dr. Jones or whomever who has their own practice, or maybe a couple practices in a town or community with a couple doctors. So to kind of continue where you're at that mindset, I want to just highlight a couple things. One, I love that you said you wanted to learn from your cases. I love that, and you felt like you weren't in that environment where you were just kind of fixing other people's cases, and you wanted to start something from beginning to end. And we're going to talk about that in a little bit when we talk about how your treatment approach has evolved. I learned more from studying my beginning and my final results than anything else, any course I took, anything I did. Not that the other stuff wasn't valuable, But I find so often, especially in a busy practice, we are so quick when that patient's braces come off, whether it's a phase 1 or phase 2, to just be like, okay, they're done, retention, and move on. And I sat down with every single final records of every single case I finished over almost 20 years of private practice and looked at every picture and every image from that patient's completed records. And I did it as I prepped a letter to the primary care dentist. And I also would look at what I did well and what I could have done better. And that's what started me seeing things that we're going to talk about in a little bit about, wait a minute, something's happening here. You know, I'm seeing things happen that maybe I didn't learn were going to happen, or maybe I'd never experienced were going to happen. But honestly, Kristen, if I never took the time to look at that, I don't think I would have ever figured that out. And I wouldn't have become the provider that I was able to be to my patients. So again, I want to commend you for having that foresight so early in your career that was something valuable. The other thing is I want you to just go a little bit more into the financial discipline you had for delayed gratification, because you said that when you were working initially, you were saving, and you were living in a modest apartment. How did you know to do that? And was it hard? And what do you say to people who are struggling to do that? Because a lot of people come out and they want to get the nice house, the nice car, all of those things right away. I tell residents all the time, you're probably never going to live more humbly than you are as a resident. So just keep that going for a little while, maybe make a couple minor increases in your lifestyle. You have plenty of time to expand your lifestyle, but it's really hard to do. So how did you do it? And what advice could you give to others about it?
Yeah. So, I mean, I think it's all about finding some sort of balance. So for me, I was spending a lot of time in my car. So the one thing, like, once I had a car that was in Connecticut, and the one thing that I was like, okay, you know what? I'm really working hard. I'm going to get a nice car, because I was driving all over Houston. Some of the offices were an hour away. I was working in 5 different locations. But I didn't need this massive apartment. It was just me. So, I lived in like a 900 square foot apartment. And the nice car kind of satisfied my like feeling of like, okay, I'm working really hard. I deserve something, you know?
Yep.
So I felt like it was a good balance. And then I lived in a small apartment for quite a while. Even once I was a year into opening my practice, I still kept that apartment because I just needed fixed bills.
So smart.
And that was
so smart.
I also think that, it's easier as like someone that's single. I know it's very different when people have a family already. If you had a family in residency and you have kids, and it's not feasible to live in a 1-bedroom apartment,
Right.
That's 900 square feet. So there were definitely some things that with it just being me, were easier, but I also knew that I didn't have someone else to count on. It's not like I had a partner with an income.
I was going to say that. Yeah, there's 2 sides of that coin. You're exactly right. Yes.
It was me and only me that was, responsible for taking care of myself.
Yep.
So it definitely made me realize like, okay, if I want to open up an office, I have to save up a bunch of money and I have to prepare and plan. Honestly, it's a really good thing that I did, because I opened my office 6 weeks before the entire world closed down.
That was another question I had. So 2020, people, I said open our office in 2020. There was a lot of people who were probably thinking, wait, did what? Yeah. Talk a little bit more about that too. I mean, what was that like?
Oh my gosh, it was probably the most stressful time of my life. I was questioning.
So you opened just before it. You opened in the beginning of 2020.
Just before.
Oh my goodness.
So in the end, it turned out to be kind of a blessing in disguise, because while everyone's stressing, like, what do I do with these 60 patients? I could space people out all day long because I only had, 5 people coming in the door.
Yep.
So in the end, that was a blessing, because like I didn't have all these people in active treatment that I had to worry about.
Yep.
I was still working my corporate job. So that was the other thing that I think is critical. And the reason that I was able to open an office and not be so stressed is I kept that job 2 to 3 days a week until my practice could support itself.
Okay.
And I think that made me a better boss, because I wasn't, over analyzing every expenditure, like every number, and stressing out over it. I could, be the best version of me because I was paying my bills from my other job.
Got it.
And
that's interesting.
I saved up a lot of money. I prepared. I didn't quite prepare for, everything to close, because I was on like a per diem or a production setup with my corporate job. So if I'm not going to work, they're not paying me.
Okay.
So that was a little dicey for a little while, but luckily they did a lot of like, loan extensions and, things like that helped offset some of those costs initially.
Yeah. Wow. That's interesting. The timing of things and how something that was a really bad situation you made the best of. And yes, I know personally what it was like trying to manage my schedule when the world shut down, and my goodness, that was intense. That was very intense. I was already booked out many, many months on even new patient exams, and it was just brutal trying to find, and we didn't know when to reopen and when to put them. So we kept like rescheduling them for 2-3 weeks down the road. Then another, it was crazy. But so it's interesting you were able to kind of capitalize on that time of being able to focus, build the practice when everything else was kind of shutting down. But the thing is, you had the financial discipline to save. And so often young docs, and I find it's really interesting what you said, and I like that. You gave yourself one thing that felt like you were rewarding yourself, because again, we do go through a lot of work. For those who aren't aware, it's typically about 11 years after high school to become an orthodontist. And it's a lot of time, energy, and cost and dedication and sacrifice to do it. And so a lot of people do get out and they want to have some sort of reward for themselves. So it sounds like from what you're saying, you want a nice vehicle to travel in, and that was important to you, but you didn't go get the nice vehicle, the nice accessories, the nice everything, and literally spend everything that came in. You created a margin between what you made and what you spent, and you did you save that? What did you do with that money?
Yeah, I just started saving as much as I could, because I put in like quite a bit of cash into building my office, because the loan alone doesn't cover it. So Bank of America, for example, will give you like typically about 500,000. And I wanted to put in 7 chairs. I have 5 in an open bay and then 2 consult rooms. And my whole thought was like, I didn't want to go too small to where I couldn't grow into it. So I was trying to find the right balance, because construction is expensive. Fortunately, I actually kind of like built my office at the peak. It got really expensive after COVID.
Yes.
So I was fortunate in that, regard. But I didn't really know how much I would need. The other thing that I started doing is, once I started getting into the build out process, I would just add Saturdays here or there. Like once I was really understanding what everything was going to cost, because I wasn't sure. I learned creative ways to like finance my equipment through like Benco instead of putting it under the Bank of America loan. So it was like a separate loan, and I could get, an extra 130 grand or something. So little tips and tricks like that. But I kind of figured it all out on my own.
That's impressive.
Because my closest friend bought into a practice. So that was the person that I would, talk to about cases all the time, talk to about private practice. But he bought into an existing practice, and then, just recently bought out his partner. So it was a very different journey.
Yes.
I feel like I teach him certain things about the business side, because his partner was always doing that. And he was, the one that came in second.
Yep. It's hard. And that's one of the things that with my platform, I'm not there yet, just because I've got a lot of things I'm building and growing, but eventually want to get to the point where I'm doing some more, I do some coaching on some of those decisions, but really help people with that transition from how to do a lot of what you had to figure out and kind of reinvent the wheel. And obviously you've done it successfully, but could you have, if there's some resources there of someone who had done it and you to turn to, just as a mentor, someone to be able to be there to help you with some of those decisions, who had done it before and not that long ago, I think would be great. So that's something I kind of have on my goals list to be able to start to provide, and even incorporate with my wife, who was my practice admin. She ran the front end to start to help people with their systematization and building their office infrastructure and human resources and compliance and all of those sides of the practice too. And then my clinical acumen and clinical systems and so forth. So before we get into which we'll get into in a second here on kind of the technique side of things and your evolution as a clinician, how did you figure out how are you, because you're early in this, how are you figuring out and managing building those systems, knowing what technology to incorporate into your practice, knowing what to do in particular certain cases that maybe you've never seen before? What are some of the tips and tricks you could offer to younger docs or people that might be in a similar situation to you?
So to me, one of the biggest resources has been colleagues, not necessarily directly into the forums, because I feel like sometimes you get, there's some great tips in there, but there's also like a lot of negative comments. So for me, it was more, at least I think I'm fortunate as a female, the women in orthodontics group is extremely amazing.
Okay. Yeah, I've heard that it's a great group.
It is phenomenal. And they are so nice and they're so helpful and they're very supportive. And so even when, I was kind of trying to make certain decisions, there were so many people that if I would post a question in there, they're like, here's my cell phone number. Feel free to reach out.
So
I
cool.
don't feel like I see that as much in some of the other ones.
No. Courtney Levine was on a while back on my show, and she mentioned the same group. She said it was huge for her and has been a great resource for her.
Yes, they're amazing. There's also another really good one that was created for startups called Orthodontic Startups Only.
Okay.
And I joined this one after the fact, so I'd actually already opened my practice. But there's so many tips, like people are so willing to share their employee manuals,
Wow, that's awesome.
Systems and things. And to me, that's how it should be. Like unless you're opening up next door to me and trying to compete with me, we should be helping each other. Yeah. We can all learn from one another. But otherwise, it's just been kind of learn as you go.
Yeah.
Fortunately, in the beginning, when you open up a startup, you do have time. So it gave me time to kind of develop certain systems and figure out how I wanted to do that. But it's evolved drastically, even from the way that I do my consult to the way I do it now.
Yeah. Because in residency, we're learning 3-step, essentially. We have the patient for a new patient exam. You get them back for records, maybe take records that day. And then you treat and plan the case. And then you come back and present the case to them, and then they come back at another time to start treatment. So if you add in the treatment start, it can be a 4-step. So you're right. It's we're not taught that.
No. And then, some of it is literally just trial and error, at least with staff and managing all of that and figuring out what works and what doesn't. But I definitely at least with a DSO, they have a lot of really good systems. That's one thing that, they have a whole HR team. They have a legal team. So you can learn a lot from a company like that, even if it's not how you want to practice.
Right.
They'll still teach you plenty of good things about the business side.
Yep. Yeah. The infrastructure is sound. It has to be. It has to be.
Yeah. Exactly. If they're going and repeating it, they're doing something right.
Yep.
They're not holding on to doctors. So I feel like, there's other aspects of it that need work.
Yep.
But there's still definitely something to be, taken away from it. And that's what, when I would give a lecture to the third years at UConn all the time, I would always tell them too, even from the negatives, you're going to learn something and take that and do the opposite and learn what you don't want to do. And that's still just as valuable as someone showing you a positive tip.
Yep. Agreed. That's a great point, and not be afraid of those negatives and just learn from them, learn
from them.
Yeah. Yeah. Don't get beaten down by them. Don't get discouraged, but keep it in perspective and learn from it. So it sounds like you had a vision. You might, even though you might not have clearly defined it, it sounds like you definitely, just speaking with you, you were always watching these things, the wheels were turning as you were in these different situations, and really always analyzing, not just what do I want today, but what do I want my career and life to look like down the road, and where am I going to be the happiest? Is that fair to say?
Oh yeah, 100%.
Yeah. And
even when I was in a situation where I could very quickly recognize that this wasn't for me. Maybe I didn't have my path to get to what I wanted figured out, but it was this is not it. And I need to go back to the drawing board and figure out how to get to that end goal.
That's awesome. Well, thank you for being so open on those topics. I really appreciate that. I know that is going to speak to, I know, because I not only teach residents at Nova, but I get a lot of feedback from residents. I do guest lectures at residencies, and these are some of the exact questions I'm getting asked all the time. And I really appreciate you being you being so open on that side. So taking it into the next thing I want to cover, which is treatment approach. So we're both UConn trained. I was fortunate enough to be there when Charlie Burstone was still alive and literally learned biomechanics from Dr. Burstone. And the way we're taught, the things we're taught how to be really good tooth straighteners, really good. And we're taught how to do really difficult things biomechanically. When I was there, and this isn't a criticism of UConn, this is, I don't know the exact number, but let's call it, 95% probably the residencies, orthodontic residencies out there, you're not learning a lot about what you're going to face when you go out into private practice. So just giving my own example. I found that I came out and when I was in UConn, and I've gone into a lot of reasons as to why this is. I think a lot of it is the system and the Saltzman index, and a lot of patients and residencies are on state funding, Medicaid. And so they don't cover certain things, and they do cover certain things. And they're certainly not aggressive on covering earlier treatment. So what a lot of residencies do is they see these patients. Academia has embraced this philosophy, and they might see them at 7, 8 years old, 6 years old, whatever the case might be. But unless there's like a crossbite or something very abnormal in that arena, if it's just a patient who's maybe crowded, or maybe their growth and development is altered, or maybe they're a little bit of a vertical grower, or maybe their bite's a little open, or all of the different myriad of factors, or maybe their upper and lower arches are constricted, and so they don't have a crossbite, but they have this significant transverse deficiency. We're really just taught manage the teeth, right? Are the teeth going to have room? Are we going to have to extract teeth on this patient, or will the teeth fit? And because state funding won't cover that at that age, we're almost kind of pigeonholed into an approach that we're forced to take out a lot of teeth, because if you don't get on that early and you let the patient continue to grow in that way, when they get to being towards the adolescent age, there's just not a lot of room there when you can finally start orthodontic treatment. And you have to treat the case to get the room for the teeth. And if you have to get room for teeth, you have two options: grow the patient or remove tooth mass. There was a great article in '83 by McNamara, O'Connor, and Howe, and they talked about this, and they looked at study casts of really crowded patients and not crowded patients, and they concluded that it is virtually almost the tooth sizes were almost identical in both sides. It was a jaw size problem, and they actually said that these problems should be solved more proactively and aggressively on a growth side rather than a tooth mass removal. And people can look that reference up. It was in the AJO. So the system has set it up so that we can't really do that. We're kind of forced to treat the teeth. And it's beyond the scope of today to hypothesize how we fix that and why it is, but it is what it is. And so a lot of us come out and we're forced to just kind of look at these cases as treating the teeth. But I went into practice, except within a week of finishing my residency, the first people coming in to see me as my first patient started to come in were like 6, 7, 8-year-old kids. They weren't 13, 14-year-olds with impacted canines that had never been seen before, or kids that had been seen a few years earlier and been down a serial extraction path. They're coming in, they're crowded, they don't have room for these teeth. Oftentimes they didn't even have a crossbite anywhere. And the laterals don't have room to erupt, the permanent laterals. And the parents are like, yeah, the dentist sent me over. What do we do? And I'm thinking, oh, in school, we would have started to send you for teeth or kind of watch for waiting and all that. But I'm, you mentioned, well, we could take some teeth out. And the parents are like, whoa, why I don't want to do that. Or I had teeth out and it was terrible. Or I don't want to pull healthy teeth, and all the things that you hear. So I started thinking, okay, well, why are we pulling teeth? And I actually started, when I would go back to UConn to teach, this was before the internet was as robust with PubMed and resources online. I would go to the library at UConn, and I would go early and stay late a lot of times and just pull literature and just look at the evolution of mandibular arch expansion and what Schwartz and Gratzinger figured out in the 60s and what Ricketts had figured out in the 70s and what McNamara and colleagues had published on even into the 2000s on helping develop the lower arch, helping expand the upper arch. And even at that time, I had no idea about airway, none. I just didn't. And so I was just looking at it initially as, how can I get room for these teeth? How can I fix the jaw problem? And I'm not saying get room for the teeth just because I didn't want to extract. I'm saying get room for the teeth because the etiology was a transverse deficiency, not macrodontia, not too large teeth. Mm-hmm. So I would look at these cases and I would say, well, let me try to normalize the growth, the transverse, and then see if we have room. So I started doing that. And I couldn't believe what I was seeing. All of a sudden, in all these cases, they had plenty of room. And in that journey, at that time, I was using upper and lower expanders. People here expand the lower arch, and it's dental. It's slow. And you're not orthopedically expanding the mandible. The sutures fuse, the midline symphysis is fused near birth. So I get that, but you're uprighting the teeth that steep curve of Wilson, that caved in lower arch. And I would do that. And then I would expand the upper jaw, and I would just see these teeth have room. And then I started noticing the patients look different in a positive way, right? Their faces are developing better. Their growth was better after we were in retention. And parents started asking me about, hey, Dr. Mike, do you think like the fact that he's sleeping better, he doesn't snore anymore, or, I didn't have a cone beam at the time. This is early 2000s. The ENT was watching his adenoids, and they said that they're better, and all these things. I'm just kind of, again, like we were talking about before, critically analyzing our cases throughout and at the end. And I'm thinking, and I would say to people, like, honestly, I don't really know. I know there's literature to support that expansion helps airway, but I don't know if that happened with your son or daughter. And then I got an iCat in 2014, an iCat Flex, low radiation, less radiation than a 2D pan. And then I started to really see things differently. And I started to see what was happening with the airway and the changes that were happening in the growth and development of the face. So that was kind of my journey in all of this. And then I became super passionate about it and developed ways to do it without expanders and using braces and wires and so forth. And we don't have to get into that side, but was your journey similar? Did you, because I know in talking to you, you've started down more of this path of treating earlier, helping kids younger, being cognizant of airway and the role that we can play in that. So take me on your journey in that, if you would.
Yeah, for sure. I mean, honestly, mine is extremely similar to yours. And I would agree 100% about what you were saying with like, we get no exposure. I did one phase 1 case.
I did too.
When I was at UConn.
Yep.
And I think a lot of it has to do with the Salzman index, that they're only going to cover treatment once. You're trying to not, you want to ensure that the kid gets comprehensive treatment. So they just tell you to wait.
Yep.
But mine started out very similar. I was seeing it actually, Gary Open, we used to go to his office.
Oh, sure. I love Gary. Yeah. Yeah.
So we used to go to his office, and he did a lot of like cleft and craniofacial patients. Yes. And he also was really big on expansion. And he would tell us, like, I don't have a lot of canine impactions. I expand a lot, and I don't have a lot of canine impactions. Yep. And so that really resonated with me, because every canine impaction I had they're not fun. Like, it's not something like, it's miserable for the kid. They don't like coming in. They have to come in frequently for you to reactivate it and drag this tooth in. It's not a pleasant experience for anyone. Like, the chain gets lost, you're digging it up. It's just
the miserable. Surgery alone is not fun for them to heal from. Yeah.
So that really resonated with me, because, part of why I became an orthodontist is I like being the nice one. I like having this like profound aesthetic change, but without like a lot of the pain that goes with it.
Yep.
And so I started doing the same thing when I started practicing. I was seeing all of these, cases, lots of young kids.
Was this in the DSO, or was this once you started your own?
I mean, both, but definitely I started adopting this when I was working for a DSO.
Okay.
I would see these kids come in, the canines are mesially inclined.
Yep.
They don't have a crossbite, but you can tell that there's a transverse issue. Like, all
About what age would this be?
6, 7, 8, 9.
Okay.
So canines haven't come down. Yep. So I would tell the parents, look, I actually would expand before I would take out any C's.
Yes.
So we were always taught, if you see this, just take out the C's.
Right.
But I started looking, and it's like, there's this clear drop off. Like, the anterior teeth are in one plane of space. The posterior just cave in like this. Yep. I mean, it makes sense. Like, they're getting lost because they're crowded and they don't have room.
Yes.
So I would fabricate expanders, extend the arms to the C's. And I was rarely even, not only was I not seeing canine impactions, but I was rarely even having to take out the C's.
Yes.
Just from
so
expanding, the canines were coming in. I normalized everything. And, I started to just collect the x-rays. So luckily, even though I was moving around, these were happening really quickly. So it wasn't like, in a 6-month timeline, for example, I could take a progress and see that we were heading in the right direction. In the consult, I'd tell mom and dad, we're going to start with the expansion. They need expansion anyways, because it's rare that it's happening on a case with anterior spacing. It's happening when there's anterior crowding.
I thank you.
So,
Just to reiterate what you said we need to expand anyway. We're not talking about doing this on patients who have broad arches we are talking about treating patients with a transverse deficiency. So I just wanted to highlight that. Go ahead.
And so to me, that was, even though it wasn't the way I was taught, it made sense. It was very rational.
Yeah, same.
They're getting lost because they're crowded.
Yeah.
And I rarely ever had a parent that was like, no, I don't want to do this. Like, you can show them the x-ray and they can see it.
Yep.
So like you, I wasn't looking at airway. I wasn't paying attention to any of that, but I've always been someone that really analyzes all of my work. Mm-hmm. So with those, like I was saying, like the timeline's shorter. So pretty quickly I was like, man, this is looking great. Mm-hmm. And then, if I didn't see lower uprighting or I had lower anterior issues, I was putting brackets and wires on the bottom and just to compensate and match the upper expansion.
Yep.
And when I was following these cases, especially when I was implementing this same thing in private practice, they're coming back, and a case that maybe 5 years ago I thought was headed towards extractions, and it was a clear 4x case.
Yep. Things
were erupting nicely, and like I was even at my phase 1 consult telling the parent, years ago, there's a good chance that we might have to extract teeth. We're going to do this. Mm-hmm. Now that's, my verbiage is very different, mm-hmm. but my mindset was always like, it's easier to like prep them for the worst. And then if we don't have to do that, great. Mm-hmm. And I never loved the look of extraction cases. Like I never wanted a practice full of extraction cases. Mm-hmm. It's easier at times. Like if a patient comes into you and they've got blocked out canines, you take out the 4s and the canines drop in and you just do a little alignment.
Yeah.
But like you, I feel like it's not addressing the root cause.
Yeah.
It's not addressing why we got here.
Yep.
So that kind of sparked my like interest. And from looking at my own cases, I'm like, oh wow, if I see them younger, I'm not really extracting and I'm not having impacted canines. Like this is amazing. And it was very profound and I just started collecting my own cases that I could show parents and consults. And it became very easy to explain why we should do something now instead of just watching until things collapse in further.
Yep.
And we also know, like, it's very well studied that the transverse dimension stops first.
Yep.
So I've never had an issue when I'm seeing a 6, 7, 8-year-old when the parents are like, are they going to grow out of this? No. They're going to continue to grow down and forward, but they're not, the width is not increasing. And if anything, when you have one dimension that's restricted, it's going to offset and affect the other dimensions.
Yes. It's a huge point. It's a huge point that we don't learn, I shouldn't say we learn. The thing is
we learn it.
We learn this. Like we study growth and development probably more than any medical or dental professional out there. Yet it's one of the things you probably hear in my voice. Like I got to take a breath. It gets me so frustrated because we learn this and then we don't apply it and we relegate ourselves to tooth straighteners. Like I can't affect growth and development. I can't do anything about that. I still don't understand why. I understand, and I agree with you. It's interesting because we haven't had a formal discussion about that part of the kind of why the system is broken, so to speak. But it's interesting that we both have a similar thought about that. What I can't reconcile is why our colleagues remain so resistant to it, even when they hear the stories of someone like yourself, someone like myself. And I've put my content on this stuff out there, in a lot of content out there for people to observe and look at objectively. I've put the research and the literature and the data out there as well as my own cases. But people just continue to remain myopic and very dogmatic and closed-minded on this. And I've never heard somebody talk to somebody. And I say this often in my email, I put it in the show notes. You know how to reach me. People know how to reach me through my YouTube channel, however you want. Please reach out to me if this is you, because I've never met that person yet, that you've done something like what Kristen's describing, like what I was describing, and you've started treating kids a little younger, and not just once or twice, but given it a fair chance and really looked at your cases before, during, and after, and saw the changes you were able to achieve. And we're going to get to airway in a minute, but forget about even the airway side of it right now, right? Let's just talk about treating the etiology, which is the transverse deficiency, the etiology of the crowding, which is the transverse deficiency, not macrodontia, who's taken that approach and been more aggressive on phase 1 and has said, yeah, I don't want to do that anymore. I don't think that works. right? Like, I mean, it's exactly the opposite. It's exactly what you just said, that once you started seeing this, you're going, oh my gosh, I'm not dealing with impacted canines, like hardly ever, unless it's just a genetically malformed ectopic tooth. A lot of times those would be the ones that'd be like complete horizontal, sitting up, near the nasal floor. And no matter what space you made, that thing wasn't going anywhere. But you're almost not dealing with impacted canines. It's phase 2. Sometimes they don't even need it. I never promise parents that. I always explain expect it, but sometimes they don't need it. And you're the hero to the family when they don't need it. And you know, instead of breaking them the bad news, if you didn't do a phase 1, that now this, almost preteen to teenager is going to need 2 to 3 years of treatment to try to fix the watchful waiting that you did over the past 5 years. And when they do need it, it's really straightforward and easy. If you like clear aligners, it's often very treatable with clear aligners. If you don't, simple fixed ortho will take care of it. So when people give it a chance and they really do it, I find that they become as passionate about it as you and I are. Is that what you've experienced?
Yeah, 100%. I mean, I think the other thing to me that's very interesting is like the people that will say, I can't believe you're doing all this so early. Like, we still believe in Herbst and Mara, right? Like, we still believe in some form of like a functional appliance. People will still use these to correct a class 2. Why? Because you think that you're going to do some sort of growth modification. So if you believe that at 12 or 13, when they're at a peak growth spurt, why wouldn't you try to correct something that you can't capitalize on a growth spurt anymore? Like, it's only going to get worse.
Yep.
So like, if you use the same philosophy, like, to me, it applies. And then, my other point would be like, I think that there's so much push in just like society today and healthcare with like people like Peter Attia and Outlive and that we should be looking at like the root cause. And there's nothing like, would you want your medical doctor just watching and waiting? Like, that's the whole thing that he says is like healthcare 2.0 versus healthcare 3.0. You want to get on things early and catch things before they're an issue later. So why wouldn't, like, that's what really sparked my like journey and thinking about airway more. Is like, why wouldn't we apply these same principles? Like, I'm in my late 30s thinking like, okay, I need to start paying attention to all of this. And if you apply those methods and those same principles to orthodontics, you should be looking at young kids. You should be treating them before they're 14. And people are so into it. Everyone's into the biohacking, and the like longevity stuff. So like, and especially I would say if you're a provider that thinks that way, like, why aren't you looking at your own work the same way?
Yeah. And the studies are out there. So many times I'll hear people in our profession say, nothing in the orthodontic literature says that this is, that's false. And I go over that a lot on this show and others that I appear on. And that is not true. There's lots of articles, especially from McNamara and Bichetti. And Bichetti was advocating, who's sadly passed, but he was advocating, has studies out that show that treating in, I think it was one was in 98 that he published in European Journal of Orthodontics, that showed that treating class 3s in the primary dentition is easier and more stable than waiting. So you have a lot of data out there. People can pick and choose what they want. That's where articles and data, and Peter Attia talks a lot about this, right? You can kind of pick studies and use studies for whatever purposes you want to advance your own agenda. But when it comes down to it, there's a patient at the end of this. And we do know it's not debatable. I mean, Karen Bonnick had an awesome study in 2012, and David Gozal's done a lot of publishing on, these are physicians. David Gozal, I believe, is the dean of Marshall Medical School, looking at thousands of patients and looking at and there was another one, Isaiah, that was out in 2021, I believe, looked at data across the adolescent brain cognitive development study, like 10,000 patients. And they're showing not only behavioral deficits, but neurocognitive deficits in young patients. These are typically in the ages of 4 to 7 years old. They're looking at these patients. And neurocognitive deficits, so behavioral, a lot of people know that sleep disordered breathing or other issues with sleep can cause ADHD symptoms and other comorbidities. A lot of people don't know that the medical literature shows very clearly it causes neurocognitive deficits as well, and that these kids have inhibited learning potential. These kids fall behind in school when they have even I believe it's the Isaiah study, as so much as heavy mouth breathing, at night. So we don't learn this in our residencies. When I teach the residents about this stuff, they've never heard this before. They don't even talk about airway. So the system needs to be fixed, because anybody who comes out of school and says the data aren't there, I give them a little bit of grace because they probably have never heard of or read the data, because I had to go digging and pick the brains of my ENT colleagues and my allergy colleagues. And in doing this show, I mean, just what I've learned the past year, interviewing people who are way smarter than I am and know way more about this stuff than I do, and just hearing what they say and then go checking on it and saying, oh my gosh. And the more I do it, the more I'm encouraged in a lot of ways that there's more people talking about this, and we're all becoming a little more aware of this as a profession, but I'm discouraged that so many people still refuse to acknowledge it. So how did you, as a new practitioner, especially someone like me, I'd been out there, when I started realizing airway, I'd been in practice at that point, probably maybe 10 years. I started getting a little more airway aware, maybe 5-6 years into practice. So you're pretty early into practice, into your own private practice. How did you start realizing that airway plays a role and is important for us to be aware of? How did you talk to parents about it? And that's kind of part two. So how did you realize it? How'd you talk to people about it? And then how did you start to work with your medical colleagues and develop treatment plans that were centered around it?
Yeah. So I would say probably one of the biggest people that has influenced me is Dr. David Alfie. So he is an orthodontic surgeon in Houston who's absolutely phenomenal. I mean, his work is amazing. Anyone listening, you should look up his Instagram because his cases are just absolutely insane. He and
I spoke at you put us in touch, and he and I spoke yesterday, and he's going to be coming on in a few weeks. We're going to get him.
This is really exciting.
Thank you for that connection.
He lectures all over the world. He's phenomenal. And his Instagram is very informative, and it's really, I don't know if you've looked at it yet, but it's really great for lay people and for healthcare providers. It really is amazing. And so he started, he was doing orthodontic cases, but his whole focus has been towards airway. And he does a lot of advancement surgeries. Even if he's doing a setback, he's very careful because of the airway. And I was listening to the Audrey Yoon lecture, and she was talking about her brother and how he had this 50-50 procedure and had airway problems after. So I feel like to find an oral surgeon that is airway focused is very, unique and amazing. So I was sending my cases to him anyways, but of course I wasn't really treating Bimax protrusive cases yet. I wasn't really diagnosing that for surgery. But I was seeing all of these cases that I'm like, man, I probably wouldn't have sent that patient for surgery, but he's showing the pre and post CBCTs on his Instagram. And I'm like, whoa, this is kind of mind blowing. And what have I been missing? And one day I'm scrolling through it, and he's talking about how he was like, look, I really think we should be limiting orthodontic extractions unless we're decompensating, or, it needs to be for very specific reasons, not just because of crowding. The problem is that the jaws are too small. It's not that the teeth are too big. And it just really resonated with me because I'd already been kind of thinking about this a little bit, but I literally filled out an extraction referral the week before. So I went down this rabbit hole. Literally, I think I stayed up half the night, and I'm digging through the women in ortho forums, digging really deep into his Instagram. And I came across a lot of the women were look up Shireen Lim, look up Audrey Yoon. So I started looking at their research. I read the book. I think it was Breathe, Sleep, Thrive.
Yep, by Shireen. Yeah, I had Shireen on in January. It was great.
Read the book in a weekend, and I was like, oh my gosh, back to David Alfie. I'm like, now I need a myofunctional therapist. Can you help me? And he's been great. He's helped put me in contact with a lot of people because he's in this community of airway focused providers. So I knew I was he's my guy to help get me the right contacts that I need. But also it became this amazing tool. Before I was going through all the steps with my patients, you can look. I'm look at this case. This case looks very similar to yours. Look at the airway before. Look at the airway after. This patient can breathe. And he might talk about this when you interview him, but he was noticing, not that he was looking at this initially, but all of these patients with joint pain. Once he was doing the surgery, the joint pain was going away. And a lot of it is, you've got these heavy clinchers and grinders and they're doing it at night to advance the mandible forward so that they can breathe better.
Yep.
And it was just like this light bulb went off, like everything started connecting. And one, he was someone that I already had so much respect for. No one can ever deny his work. Like if you look at his work, it's, I mean, insane. And so
insane.
It's really phenomenal. And so for me, that was like, okay, I'm not doing enough. Like I need to get on his level over here. Like he was inspirational to me in that way. And that's what made me like really start kind of digging into it more and more. The myofunctional therapist he recommended runs like this Houston Airway Study Club. She was phenomenal, like gave me all sorts of resources. I think I got an article list and like TED Talks and YouTube videos. And I just started kind of digging into it more and more. And then she was like, listen, there's this amazing sleep education consortium. It was put on by a sleep neurologist. There was medical and dental people. Kevin Boyd was speaking, Mariana Evans, David Alfie, the ENT that I've been using. And I went to that course and literally on Monday, like my whole treatment process changed. Yeah. I spent the weekend like following Kevin Boyd around, asking him questions. And it was just like, there was no going back. Yeah. Once I'd already been like, I'd read Shireen's book. I'd done my own research and it was all kind of starting to like piece together. But this course was set up to kind of give you a roadmap of, even if you're just asking this simple sleep questionnaire, which is what I started out doing. Yep. Start with that. And I figured, you know what's the worst that can happen? I don't know what to do. So I refer them to someone else. At least I can sleep knowing that I'm helping to diagnose it.
Yep. Great point.
And that was how I was gained the confidence to just like jump in on it. Is I was thinking like, I got all these people's contact infos from this course. Like I even emailed Kevin Boyd a case one time and he got back to me, told me what he thought. And, everyone is amazing in this group, like they are. Of people that believe in airway. They want to help you. And I figured, I had the resources now. I got everyone's contact info. And if I needed help, I would reach out for it. Yeah. But I couldn't just like sit there and watch anymore.
Once you see it, you can't unsee it. A lot of us in the airway are going to say that. And once you know, you can't trick your brain to try to believe that you don't know anymore. And we all go into this to help patients. We're empathetic by nature. We want to be caretakers and caregivers and providers to our patients. And then once you start to open up that Pandora's box of the literature and the cases and what we're not taught in school, and you start to see this, it does. It's literally an epiphany you have. And there's like a light bulb moment where you start to say, oh my gosh, this all makes sense. And I think it makes sense because of our knowledge in craniofacial growth and development, because of our knowledge of evolution and of even the anthropological side, which on Kevin's episode on the podcast, we got into a lot more. And I even learned from him on a lot of that. But then I'm like, yeah, wait. We read articles, we read Harvard studies on the rhesus monkeys in the 70s and in the early 80s in the AJO. And we read Coracini's studies. And so we read this stuff. I mean, I literally had archives when I moved from New York to Florida, folders of articles from my residency, because everything was paid. We didn't have digital formats back then. So it was all paper. And I literally have these articles, Coracini's 84 article in there. I mean, the Harvard studies, all of these, rickets studies, all of these things that show that, slower maxillary expansion works in younger kids and all these things. But I don't know, we learn about it, but we don't learn how to implement it. And then I think once we go out and we see people implementing it, because we have those two facets, the caretaker and the provider. And then we also have the knowledge of what's actually happening in these patients. Then we see there's another way to do this. It really opens our minds. And on that, why do you think, sorry, the two-part questions here, but two parts on this. One part is, have you faced resistance from your ortho colleagues? And number two, how would you, I guess, kind of relate to that, how do you handle that? And what would you say to those who are so staunchly against this, those who speak and say there's no reason to be treating these kids younger, there's no reason for the orthodontist to have any role in airway?
So fortunately, I haven't really gotten a lot of negative feedback, but I've mostly talked about it in like with other women or the women's group. And I feel like
I
partly
say that a
because
lot. Yep.
they are so open to it. I don't have kids of my own, but they're so open to it because most of them, their journey started with their own child. Like you,
Yep.
I'm sure hear that over and over and
I
over.
do.
And it's one of those things that like nobody knows their child better than their mother. Like they pay attention to all these little details, all these little things. And so they knew something was wrong and they go digging for answers. And so they saw it firsthand.
Yeah.
And that I would say is like the story for 95% of the women in the ortho forum. And I think why they're so open to it, but plus they're just nicer to each other in general. Like they're not keyboard warriors saying crazy things.
Yeah.
So for me, I've been fortunate because that's maybe been more of a resource,
Yep.
but you'll still even see like there's a couple people that are very big in airway and if someone's asking about it, they'll say like, here's my cell phone number. I'd be happy to talk to you on the phone about it.
Mm-hmm.
I'm not getting into this online because of all the negativity that sometimes, comes up from it.
Yep.
So
I've done that and offered to message me on Facebook. I've given my email. And I hate to say this, Kristen, but not one has ever taken me up on it. And I think that does speak volumes. And I would, I've tried to offer to have debates with some of these people and open forum discussions with these people. No one will take me up on it, which to me is very telling, because if someone reached out to me and said, I want to have an open discussion with you on this topic and I want to debate you on it, or at least hear why you feel the way you feel, I would make sure that I found the time to do something like that. Not to prove I'm right, but just to help get the message out there and expose people to my thought process on it and learn about theirs and why they think the way they think. So I agree with you. Everyone who I've gotten to know in this arena and in this phase of my career that I'm in now, who does have an airway awareness, is amazingly open, amazingly passionate, empathetic. They are driven for the purpose of advancing patient care. People are like, oh, they have ulterior motives and it's to make money or sell their own products. I have yet to come across one of them who that is their focus. They might have a product or they might have a platform, but everybody needs a platform or a product to try to educate. If you don't, they kind of paint you in a corner when they say, well, you're just trying to sell something or promote, for me, like, oh, you're trying to promote your show or promote your C courses. Like, I offer this because if I just were to say randomly that this is something, then you would say, well, you don't offer anything to back it up. So they get you kind of coming and going, where it's like, well, then you back it up. It's like, well, now you're just trying to promote the stuff you're doing to back up. And as you said, a lot of times on social media, this stuff devolves very quickly. And I agree. It tends to be a lot of the men that, we get kind of puffed up and put our chests out there. It's like, it gets this battle and it overshadows a lot of colleagues, probably, as you said, especially some of the women who see this and sense this more than a lot of the men because of their maternal instincts, because they are able to sense this in these kids. I said, going way back, and talked about it with a bunch of the female guests on my show, that probably Stacey Becker was one of the first ones I talked to about it. And I've since talked to many others. And that is, I just sensed from as I got into this, that my female colleagues were way more receptive to it. They were the ones reaching out to me saying, hey, I see some of what you're doing. I found the same thing. I'd love to learn more about this. Or, I'm trying on my own journey in this, and I don't have the confidence. And it tends to be the male colleagues, especially in the orthodontic arena, and I'm not being critical of them. I'm literally just calling it as I've experienced it. They tend to be much more resistant to it. Now, interestingly, in the non-orthodontic arena, I don't find as much of a disparity. I find that a lot of the general practitioners and pediatric dentists with whom I speak or who engage in my content or I coach, a lot of them, it's probably 50-50, male, female. So there's something about, as a male orthodontist myself, I can certainly speak to this. There's something about why we don't want to let this go and give up on the sort of, this is the way we've always done it. This is the way we need to continue doing it. I don't know what that is, but I'm encouraged that you feel that there are so many people that you're not getting and feeling a ton of resistance. Because when I was practicing in upstate New York, oh my gosh, the resistance I got when I was doing early expansion, let alone when I then started doing it with braces and wires and focusing on airway, it was like, it really, really, really a lot of arrows in my back on it. Interestingly, people didn't talk to my face about it, but they would say, I'd hear things that would be said. So it's encouraging for me that you are finding that you're not seeing as much of that in your professional circle. I love hearing that. And that means we're making progress. And that means we're starting to raise awareness with enough people that enough people are saying, wait a minute, this isn't new. This isn't outlier stuff. This isn't quackery and things it's been called by certain people in our profession. This isn't over treatment. This isn't over medicalization. All those things that you hear from sort of the key speakers on the side against this. This is where we need to go. And Peter Attia, I love that you brought that up as well, because that's the whole premise of his Outlive platform, and is we need to get away from this reactive mentality where we're treating late and end stage disease, which treating malocclusion in a teenager at that point kind of is.
Yeah.
Right.
I mean, Kevin Boyd calls like a 9-year-old geriatric.
Yeah, I know. I love it. Yeah. It's, he's had so many great terms that he has coined. He's craniofacial respiratory complex. I mean, he's just such a bright guy, and his combination of intelligence and affect and social skills is so unique. And I mean, it's rare I talk to somebody who's newer in this arena that doesn't say that Kevin had a profound impact on their trajectory. And I told him that in the episode we had. He's very humble, but I said, and I meant it. I mean, it is rare. So where are you now in that, in terms of the airway side of things and the treatment side of things? And what do you see as the role you can play going forward? Are you using cone beams now? How do you talk to your patients about this? Are people coming to you because they know you do this? Just if you could kind of touch on what this is like in everyday practice. Yeah.
So I upgraded my PanCef, because when you do a startup, budget's very limited. So I got a v.Dr. PanCef. Part of why I went with v.Dr. is because I could do an upgrade where they buy it back, and you just pay the difference. Oh, so nice. I did the buyback, and I got their green low dose CBCT. Yep. So it's a great option if someone I just didn't have the funds. I was tapped out on everything and couldn't go all in on a CBCT from day one. And I wasn't in this arena yet. So it was harder for me to justify. Yep. But there's something in the back of my mind that was I think I'm going to want that one day. So let me buy this so that I have that option. So I recently upgraded my cone beam. So now I'm taking that routinely. But even that's been just a newer transition. Initially, I was only taking it if there was positive responses on the pediatric sleep questionnaire. So the way that I had it set up was that my TC was going over the medical history and the pediatric sleep questionnaire. I think that's critical to make sure that you have a person asking those questions and not an online form. Because we know how many people are just no. Yep. And then you start looking at them and you're asking more questions. They're oh, actually, yes. I don't know why I clicked no. Yeah. So
Dad did that at 11 o'clock last night. I don't know. He doesn't know what he's talking about.
So my TC goes through all of them while my records tech is taking the photos. And then if there was anything positive, I was just taking a cone beam then. Okay. Now I'm transitioning to, because I didn't like the idea of, I didn't want to double take one, take a PanCef and then take it.
Yes. That's kind of the residency mentality, and it drives me crazy.
Yeah. But it was hard. It's hard when you're used to it, and my PanCef just pops up in my practice management software. And I have a very busy practice. My office has, grown exponentially. So I've had to kind of take some baby steps on implementing it and make sure that I can do everything in a systematic way. Yep. But starting to take that has been life-changing. Mm-hmm. And then just from, that questionnaire, plus with some of the stuff, a ton of the stuff that I learned at that sleep education course, there's so many warning signs that we should be looking for. When you look intraorally, shape of the palate. Doesn't matter if there's not a crossbite. Is it vaulted? Is it narrow? What does the tongue look like? Is it spilling over onto the occlusal surface of the lower teeth? Is the tongue restricted? Which typically, if the palate's not developed properly, the tongue is restricted. Yes. Looking at tonsils. I never looked at tonsils before, but now I pay attention to them. Yep. Do they have dark circles under their eyes? There's just this really clear phenotype. Now my TC comes and gets me, and she's there's an airway problem.
Right. No, I had the same thing. Yeah. They're oh, I can't wait to hear what you say about their airway. Because they were excited because they knew we were going to really help this kid. Your staff gets excited about it too.
Exactly. And I feel like that was one of the things that like really resonated when my TC got on board so easily, because I was able to, she has her own concerns with her son. I was actually asking Kevin Boyd about them at the meeting, and he's like, why don't you take her and her son to Chicago, and I'll treat him and teach you what to do. I'm like, okay, well, maybe once he's well behaved enough to get on an airplane, we'll consider this. But so from kind of my own staff's experiences and things, I was like, okay, I'm on to something. Like everyone is being very receptive. And then when I'm like pointing it out to parents, they have no issue understanding it because it makes sense. It's logical. Like you read Shireen Lem's book and it literally talks all the way from the beginning of, you know, breastfeeding on to like how the, you know, if there's any sort of difficulty latching, like you're going to see all of these common themes. And usually if you start even asking the parents about that, or they offer that up, like, oh, actually they had trouble latching, had trouble breastfeeding. Like it just makes sense. And like the story, the dots all connect. And Audrey Yoon made this comment, and it's so true. It's not hard to explain it to the parents. They understand it because it makes sense. So once I started just gathering the information, you know, I know enough from the years of practice. It was more just like piecing it together and kind of changing the way that it was being presented. But I was presenting it previously more about crowding. Now I'm asking more of like, you know, the airway questions, but I'm still telling parents, I'm like, listen, this is one piece of the puzzle. It's not going to be just me for us to address everything that's going on.
Glad you said that.
And we're going to see an ENT. We then need to see a myofunctional therapist. Once we have like created room for the tongue and it has a house that it can fit in, then we need to make sure that like the swallowing pattern is correct. If sometimes I've noticed that like they kind of adapt and it doesn't seem nearly as bad as it was like pre-expansion. Like
without a doubt.
I don't know that every single patient that needs expansion needs myofunctional therapy, but I always talk about it in my initial consult. And so I'm telling them like, these are, the ENT is a must.
Especially if they're young. When they're young and you develop that home for that tongue. I found so many of them. It's no different than the thought of when they stop a habit before they develop the mature somatic swallow. You know, if they keep that infantile swallow habit going too long, like 4 to 6 years old, it's really hard to reverse it. It's kind of the same sort of thing with a altered tongue function due to lack of space. Once you give them that home, I found that this isn't a scientific analysis, it's empirical based on my treating thousands of cases this way. But I found if you got them by like before 8-ish, you know, if you kind of got them in that window and they were done, you know, if you got them completed. So in that 7-8 window at the latest, a lot of those cases, I just had this conversation with a resident a few weeks ago. A lot of those cases, the tongue, not all of them, but started to behave on its own. It started to develop more natural function. They were able to adapt and correct. Much later than that, especially then once you get to these kids, you know, think of how many cases we treated in residency and where you don't address these growth issues young, you let them go. And then you're battling a tongue thrust on a 13, 14-year-old, giving them heavy elastics, can't get them to close it down, giving them swallowing exercises, trying even myofunctional therapy. And it's so much harder. This is why, again, the waiting is such a detriment. But yeah, go ahead. Sorry.
Yeah. Well, that's kind of my, you know, my process is I'm explaining to them that this is just one piece. There's also, I mean, like Audrey Yoon has a great article about how like there's shrinkage of the tonsil and adenoid tissue with expansion. So
yeah, that was in Sleep in 2022, I believe. I can put a link to that as well as Shireen's book in the show notes.
So that was one of the things for me that I was like, okay, well, because the ENT that I found, he's also phenomenal. His ENT practice is called Airway Alliance. Like there's not very many of them like that.
No.
But the problem is that everyone that's focusing on airway is sending their patients to him. So it's getting
Houston
a little
needs another ENT, a pediatric ENT who knows about airway. They'd be very busy.
I recently got a contact for another one that I'm going to reach out and hopefully be able to get people in sooner. But that's been my thing is like, okay, especially if it's going to be a few months. I see that the tonsils are large, but I know that they need expansion. And I've talked to him about it before. I'm like, is there anything that you would need prior to expansion? And he's like, no, get in there, start expanding, like start creating space. And so that's my, you know, timeline. I'm like, listen, I get a lot of them. You can request an appointment online. I've been having like me or my TC, we're like, here's his card, request it right now. And then I send like a follow-up email with some history.
Yep.
Perfect. But I'm like, get on the schedule so that we know that you're going to see him.
Yep.
And then we start with the phase 1 with the expansion.
Yep.
I'm still really big on RPEs, but I know like I'm in the second part of your course with the cone beam and everything, but I use 3D printed bands. So since I've done that, I feel like it is a game changer because
it does help. Yep.
I take a 3-minute iTero scan.
Yep.
Literally it pops in. I can get it out easily. There's been it's technique sensitive. Like that took me some time to figure out my protocol, but now it's very simple. Like for a lot of ways, that's actually even easier than having to put like brackets on or like isolate, because literally all we do is dry the teeth, pop it in. I put finger pressure like on the screw, we light cure it, and then go over how to turn it. Yep. So that's changed the game a lot for me and made me a lot more comfortable treating young kids, because I'm not trying to fit bands or put separators or do any of that.
Yep.
It's literally a 5-minute process.
One of the reasons I developed the archwire side of things is those things you just said, the bands, the pickup impressions, when I started doing this, we didn't have 3D. Invisalign, I don't even know if they'd come out with their first, I don't even know if iTero had their first scanner out at that point. We're going back probably like towards 2011. And so we were, definitely not. We were taking PVS impressions for aligners. So eliminating the seps, the bands, the constant falling out of a sep, all of those things were a challenge. And then the issues that bands would cause interproximally and abscesses and all of those things. So I always say, I would much rather someone go in and treat young. I mean, my way of doing it is just another way. And to me, it's important. People are getting in there, are airway aware, are having these conversations with their parents and diagnosing their patients in a way that lets them figure this out, working with their medical colleagues, and then get in there young and help develop these arches. Some people like Invisalign first. Some people, use mud braces and wires techniques. Some use different expander combinations. As long as you have it dialed in and your patients are tolerant of it and it works in the systems in your practice, that's the answer. And a lot of people who hate on this, I really feel 2 big things. One, a lot of them, well, we already talked about, it's technically 3. 1, they didn't get the training, but 2, they don't know how to manage the younger patient. So they just don't have a desire to see a younger patient in their practice. They're comfortable treating teens, and that's kind of what they're used to. They don't, because it's different when you start treating younger kids. You have to, you have to treat, your staff has to be trained differently. Your tell, show, do mechanisms. And Kevin and I talked a lot about that, your patient management side. And the other one is they haven't found a way. The third is they haven't found a way to make phase 1 really, efficient in a way that doesn't drain the resource of time out of their practice. Because if you are doing it the old school way and, doing all of these extra visits for seps and bands and pickups and not doing digital, I did it that way. That's how it was when I started. That's why I always look for a better way, because even though it was working, man, it was a lot of drain on my time and resources in my practice. So I completely, however someone wants to do it out there, to be able to get these kids growing younger, and with an airway focused mentality is great.
Well, the one thing too that I like about the RPE, and Kevin Boyd was the one that was showing cases like this too, is he was giving face masks on like really bimax retrusive cases that I would have never in a million years thought to give a face mask because the mandible is deficient. And his whole thing is like, the mandible stops growing last. So the earlier that you get on this and you correct the maxilla, the better chance you've given the mandible to correct and catch up. Or if you are someone that believes in like functional appliances at all and like growth modification at the peak growth spurt, then you can help bring the mandible forward a little bit more. Do I think we're just, drastically growing mandibles? No, but at the same time, I think you've given them a much better shot if you've normalized the maxilla at an earlier age.
Yes. Yep. It's a great point.
So I like it because on some of these where, like, I've had a couple cases recently with like pretty severe airway issues. And one of them, I talked to him and he was like, put a reverse pull face mask. So it's very interesting going back to everything I've always, been taught, like they're not class 3, but it makes sense. Like, they're very retrusive.
Well, and if they're going to need, if they're going to have to see David for bimax surgery down the road, and this is where people would hear that. And I guarantee when you said that, there's people that are like, oh my gosh, why would you ever do that? Well, if the patient has some airway issues and you can get them forward, we're doing it with adults. So would you want your
Yeah.
face cut into a bunch of pieces? As good as someone like David is to advance it, it's still a major procedure with obvious risks and consequences. Or do you want to try to help them grow when, as Mariana Evans, which she's going to be coming on the show in a couple weeks here as well, but she calls them juicy when they're little, when they're just able to like move everything around and they're just so pliable, right? I as you referenced with the analogy you made earlier with using the growth modification approach. I mean, if you're going to use it young, if you're going to be an advocate of MMA for airway, which
we all are, right? Yes.
How could you not want to take a patient who is having the same types of issues as a younger child and perform the same thing non-surgically?
And I have never had a parent say, nope, I don't want to try that. I just want to sit and watch and then we'll plan for surgery.
Yeah.
Never.
Yeah.
Even if I tell them like, listen, if we don't get enough advancement or if this doesn't go as planned, like we might be talking surgery in the future, but they still are sitting across me looking at their young kid wanting to know that they did everything possible to try and prevent that. They can sleep better at night knowing that they didn't just commit them to this surgery off the bat.
Yep.
And, the thing that's to me made it even so much easier to talk about surgery, and David will talk to you about this, but like he's gotten his surgery technique down to like 2 hours for a 2-jaw surgery. It's phenomenal.
And he said he does like over 200 a year. I'm like, oh my God.
It's wild.
Yeah.
It is. So it's made it a lot easier. Like my friend, I had one of my friends, he was my old neighbor when I first moved to Houston. It took me 5 years, almost maybe 6, to convince him that he needed jaw surgery. And he finally had surgery with David, and he was golfing a week later.
Oh my gosh. That's amazing. Yeah.
Like the surgery was 2 hours.
Wow.
And it makes it easier. Yeah. No, it's exciting. But I think that just having all of these tools and resources, and like I do have a great surgeon I know that I can send them to. Yeah. But I'm fortunate in that regard, because I have talked to people that don't feel as confident in the surgical area.
Yep.
But for me, I still see plenty of young kids, and I see, a teenager, and then the mom starts asking me about their younger kids.
Yes, all the time.
So, all the time. Or the kid just came in with the parent, but they didn't think that they even need to be looked at by the orthodontist.
Yep.
And so it's just about educating them and letting them know that there's so much that we can do now, and it resonates with them. They understand like, oh, they're still growing. Yeah, let's try to address anything that we can.
Yep. And for those who think or hear this and say, well, the AAO doesn't, says don't treat till 7. That's not what the AAO says. If you look at the AAO website, it says at any age that these are detected at 7 at the latest, no later than the age of 7. The American Academy of Pediatric Dentistry, which Audrey mentioned when she was on recently, in the episode you referenced, she talked about that they talk about going in on any growth disturbance relative to crossbite, open bite, airway problems as early as they are developed, with the intent to try to correct them however possible. So when people say that, that we're defying what we're doing, or I actually heard someone on another show talk about that, the FDA is going to be coming after you for treating too young, and alerting lawyers that if any lawyers are listening, these people going out and treating young, on what grounds? Because we're trying to help kids when they're more pliable. We can use less force. One interesting thing, and then we'll wrap up. But Charlie Tweed. So, Tweed is known in our profession as being kind of extraction and 90-degree mandibular plane angle. People think of it as that traditional ortho style. In 1963, Charlie said that knowledge will eventually replace harsh mechanics, and that we will evolve to a spot where the majority of treatment will be performed in the mixed dentition before the complicated or difficult age of adolescence. That was in 1963. Charlie Tweed said that. So we have known that we have to do better. That's over half a century ago. We've known we have to do better. And this was even the people who now people kind of clutch their pearls on, like, the Tweed philosophy. And I'm not mocking that. I'm just saying people tend to follow that discipline. And it kind of tends to be one dogma. And even he was saying we need to do better back then. Right. I mean, and it's like, we've now had all this time, all this research, all this data. How are we not doing better? And that's why I so appreciate you taking the time to come on. And so being someone who ran my own solo private practice, it is not easy to carve out some time for something like this. So I thank you so much. And, really, I know there's going to be so many people who are really, truly impacted and helped by you being so open and sharing your journey. And a lot of people tell me that it's amazing how in this virtual world that things catch on and people tell other people about it. And then I have people reach out to me and say, oh, so-and-so told me to check this out. And that's because people are willing to come on here and tell their stories and talk openly and honestly about this. And that's how we help people. And that's how we start to make a difference in this profession. So I just want to acknowledge you for the time and effort you've put into in a very short period of time, now having your own successful private practice. You didn't take an easy journey, you had nothing handed to you. You fought for it all along, and you're a real role model for a lot of people and a real example for a lot of people who are wondering what to do out there. And I know there's a lot of them and how they can do it. And I think they can learn a lot from what you did and what you've done to be able to try to take a similar trajectory if that's something they want to do. So I really commend you for that, and thank you.
Yeah, thank you. And I mean, I'm honestly an open book. So if you want my contact info or if people have questions or anything like that, I'm always more than happy to any of the residents or anything like that if they have questions.
I really appreciate that, Kristen. It's very kind of you to do. So maybe I'll just, if it's okay with you, I'll put your email in the show notes as well.
Yeah,
if people want to reach out to you directly on this. So we'll stay in touch. I really enjoyed this. We ended up going longer than I thought. I hope you're okay with that, but I was just loving.
Yeah, no, I'm good.
I love hearing your story and hearing you share so openly about this. And I really look forward to continuing to work with you and talk to you. And wish you all the best.
Thank you.
All right, Dr. Kristen Knecht, thanks so much for all you've done and for your time. Appreciate it.
All right, thanks.
All right, take care.
All right, bye.
Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening. And always remember, you have been blessed with the ability to do amazing things.